Assalamu alaikum. We'll be starting with plenary 5 and we'll have the PSIM quiz just after the 5th plenary session. Bismillahir-Rahmanir-Rahim. I'm Dr. Fibha Sayyed, Associate Professor of Medicine, Shaheed Zulfikar Ali Bhutto Medical University. And it is truly a pleasure and an honor for me to welcome you all to this 5th plenary session of the International Conference of the Pakistan Society of Internal Medicine. This session brings together science, policy, and clinical practice and promises to be both thought-provoking and forward-looking. Before we begin, may I invite our esteemed chairs to kindly take their seats on the stage. The leadership you see here reflects strength, vision, and continuity of PSIM. Professor Javed Akram, who's the Chairman, Board of Directors, PSIM, founding President, PSIM, and former Minister of Health, Punjab, a name synonymous with academic leadership and health policy reform. Sir will be joining us shortly. Professor Aftab Mohsin, current President, Pakistan Society of Internal Medicine, and truly the backbone of the society, whose tireless efforts continue to strengthen PSIM nationally and internationally. Sir, please join us on stage. Professor Muhammad Umar, founding Vice Chancellor, Rawalpindi Medical University, and Senior Vice President, Federal PSIM, with a lifelong commitment to medical education. Sir, please join us on stage. Professor Tariq Wasim, Professor of Medicine and Senior Vice President Academics, PSIM, a strong advocate for academic excellence. Thank you very much. So we now move on to our first speaker, who's going to be Professor Unal. So the next, Professor Serhat Unal is a professor of medicine in the Department of Infectious Diseases, Faculty of Medicine, Hacettepe University, Turkey. He will be talking about something that is a challenge which affects every clinician, every hospital, and every health system worldwide. He will be speaking on antimicrobial resistance, the silent pandemic, a topic that reminds us that while innovation drives medicine forward, stewardship and responsibility remain equally critical. Please join me in welcoming Professor Serhat Unal.
Bismillahir-Rahmanir-Rahim. Dear colleagues, first of all, I would like to thank the organizing committee for inviting me to this lovely city of Lahore, and the President Mohsin, and dear presidents, dear colleagues. I'll talk about the antimicrobial resistance, AMR, a silent but accelerating pandemic. I have added my fellowship for PSIM, but they couldn't change the slides, and there's the fellow of PSIM under those things too, and I'm very proud of that, being the member of this distinguished society. Dear colleagues, when we say antimicrobial resistance, we are saying that there's a bacteria causing infection, or it may be any other microorganism as well, but most of the bacteria causing disease in human body, and we kill them with antimicrobial agents, particularly antibiotics. And comes a certain time, we give the antimicrobial, we cannot kill or stop the growing of the bacteria, and this is called resistance. And it's in only one slide, it's a global health threat causing significant morbidity and mortality and economical burden. And the hospitals are the core for hotspots to produce these antimicrobial resistance, because we use antimicrobials in hospitals in a very dense situation. It's a cross-border and cross-sector problem, and we definitely need a proactive community and hospital strategies to be able to deal with that problem. So generally antimicrobials, it may be antibiotics, antivirals, antiparasitics, antifungals, but we mainly use this term for the antibiotics. But in the recent years, we started to have the resistance to antifungals, antivirals as well. And it's the antibiotics are not used only in the hospitals. We use that all around. For the animal reservoir and the environmental things. As you see over here, we are in the interaction with the environment, and when we use antibiotics in the agricultural issues, it comes back to human body again, and the same issue is for the animals. So we are not focusing on the human antimicrobial resistance in human, but we are dealing the subject with all together, and it's called, as you all know very well, One Health issue you've seen there. So it's not a problem of the mankind anymore, but it's the problem of all environment and the agriculture and the veterinary medicine, and we handle that with under one roof. It's called One Health. So you know, the antibacterials are affecting the cell in many different ways. There are beta-lactams inhibiting the cell wall synthesis, aminoglycosides, tetracycline inhibiting the protein synthesis, fluoroquinolone inhibiting the nucleic acid synthesis, and all others. Whatever the mechanism is, the bacteria can learn to get away from the effect that, and the three major mechanisms for that are the efflux pumps, enzymatic degradation, and the target modification. All those things are not the major issue. Major issue, the main reason of antimicrobial resistance is the antibiotics or antimicrobials itself. If you don't expose bacteria to antibiotics, you will not suffer from antibiotics. So what happens when we put the pressure on the bacteria, 1 in 1 million, 1 in 100 million, one of them gets out by mutation, by chance, become resistant. If you don't put the pressure, if you don't go on putting the pressure on it, it will not be able to survive because it has disadvantages comparing to the susceptible one. But as long as we put the pressure on, the susceptible ones are killed and the resistant ones are selected. So the key mechanism over here, using the antibiotics inappropriately, continuously, and creating the pressure. We say resistance, but resistance are different. We have different terms for that, MDR, XDR, PDR. MDR is the non-susceptible to at least one agent, but there are more than 3 antimicrobials in the same category that may kill that bacteria. XDR, not susceptible to at least one agent, but there's only 2 or fewer antimicrobials are still effective. And when we say pan-resistant, there's no more possibility, and we have this kind of bacteria, particularly in Turkey and Pakistan, that is practically resistant all different classes of antibiotics. And why is silent? We mentioned the title is Silent Pandemic, because the mortality because of that highly resistant bacteria are underestimated, still underestimated worldwide, and misclassified. And you may say that if there is resistance, we can come out with a new drug and we kill that. We are at the end of the journey. There's no more new antibiotics that will kill the resistant ones. So we may say that resistance grows faster than drug development. And the resistance existed not only in the hospitals, but in the environment in the last 20 years as well. And what is the magnitude of the problem? And the prevalence, global prevalence is steadily increasing. And as I've told you before, geographic hotspots identified in the healthcare settings, and it has a direct impact on patient outcome and healthcare system because everything is the same. One bacteria is resistant, one bacteria is susceptible. They do the same disease in the human, and the resistant one stays in the hospital much longer and kills the patient with a higher number of possibility. So the cost of the healthcare increases immediately because of the prolonged hospital stay and the higher treatment costs. We are talking about millions of dollars. In 2019, in the United States, it was 5 million deaths associated with AMR, and 1.2 of them directly contributes to the problem. If you look at globally, I'm sure you all are aware of that very excellent report, although it's a little bit old now, 2015. Jim O'Neill is a macroeconomist from England, and they have done a study and calculated that in 2050, first time in the world, the deaths because of the antimicrobial resistant infections will be more than deaths of heart disease and the cancer itself. we are talking about 10 million people dying every year by 2050 because of the resistant problem. And it will cause world economy of 100 trillion USD dollars. And the years, there are 10 years passed after this report. As he stated over there, we look like we are paying attention. There are lots of international organizations dealing with AMR, but in the reality, there isn't so much action, so the problem is still growing up. And the problem that it really relates us, countries like Turkey and Pakistan, middle-income countries, and the situation is worse, and it's even worse, or even much worse, in the lower-income countries. Then the problem is growing steadily. What are those bacteria we are talking about? MDR microorganisms. It's not a new subject, actually. As soon as we have been introduced by penicillin, we have seen the penicillin-resistant Staphylococci, and immediately after that, methicillin replaced, and the methicillin-resistant Staphylococcus starting from 1960s and coming up to these days, MDR Acinetobacter, extended spectrum beta-lactamases, and in 1990s, we have started to deal with the multi-drug-resistant Pseudomonas, and then recently, carbapenem-resistant Enterobacteriaceae. That's a major problem. And in the last 15 years, we started to see the azole-resistant fungus. And as I told you, the final thing is the carbapenem resistance in the Bacteriocella. And it's a major problem because we do not have any other or a better antibiotic for them. Just some small example from our countries, Turkey, AMR. We have very high ESBL prevalences. We are #2 in Europe, immediately following Greece. And in Europe, there's the resistant gradient. At the south of Europe, Greece, Turkey, France, Italy, we have really high rates. And when you go to upper north countries like Denmark, Norway, Sweden, the resistance is a little bit less. And in Turkey, we are really dealing with that, and we have recently we have a national surveillance program, but we improved national surveillance program. Although that, even in E. coli, I'm not talking about Acinetobacter or Klebsiella, even in E. coli, ESBL is 42%, carbapenem-resistant Klebsiella is 28%, major problem in the big hospitals. And MRSA, although it's going down in the world, in Turkey, we're still dealing with about 18%. And Pakistan, and I would say Pakistan and Turkey are very look-alike in many subjects. We are sharing the same religion. Our traditions are very alike. And since I was a kid, I was hearing that Pakistan and Turkey are brothers. And when I grow up and I realize that it's the reality, and I feel the same way. But unfortunately, our resistance rates are also alike, and they're not promising. And a high hospital AMR burden in Pakistan, XDR typhoid fever, typhoid is a public health crisis, and the next door, New Delhi, beta-lactamase is very high in number in Pakistan. And what are the numbers? Carbapenem resistance is about 32%, MRSA 42%, and the XDR typhoid is a problem in this part, and the further east part of the world is a real problem. And don't think that we are the only bad countries, but even in Europe, as I've told you before, and even in the United States, the MDR problem is a lot. And in Europe, the hotspots are Greece, Italy, France, comparing to the north ones, as I've told you before. And the question is, what are the drivers of AMR? I mean, we have been talking about that, why we cannot stop that. And human health, we definitely overuse, and we definitely inappropriately use antibiotics. Just think about your practice in the hospital, or just think about your practice in the primary care. Now we are in the season of flu and the upper respiratory tract infections. Flu patients comes with the headache, fever, and the cough. In my country, if the patient is suffering from fever, and if you let him go without an antibiotic, you are the worst doctor. And he's going to go to next door and get his antibiotics, and he'll be released. But we're talking about a viral infection. What is going to the antibiotic do with flu? So the major problem is the lack of knowledge among our doctors, and the major problem is the lack of awareness among the public. So that we have to convince them that fever is not equal to bacterial infection. There are so many other causes, starting with the viral infection. So the inappropriate use, of course, it creates a pressure on the flora, as I've mentioned you before. And the inadequate duration and the lack of de-escalation. When I started my practice, the treatment for pneumonia was 2 weeks, then came 10 days. Nowadays, we are talking about 3 no fever days, so generally 5 days is enough, but the 90% of practice is still going on 14 days. I mean, it's hard to convince doctor to stop antibiotics early or in appropriate duration. And the de-escalation, you have started antibiotics empirically, then you got the results of the culture. You have seen that there's some antibiotics, narrow spectrum. We have to change that, de-escalate the antibiotics, but nobody does that, particularly surgeons. And in Turkey, we have a proverb, you never change horse when you are crossing a river. So you have started a big one, just go on with that, but you don't need that anymore. So the de-escalation is important. Inadequate infection control and sanitation, particularly in the hospitals. Patient overcrowding enhances transmission. And again, in the hospitals, delays in identifying outbreaks due to poor surveillance. This is not the only drivers. On the agriculture and environment side, antibiotics are heavily used in livestock. We give 2 milligram per kilogram of a particular antibiotic to human, but we give 1 kilogram of antibiotic to a cow. And we use the antibiotics for the agriculture as well. So the high amount of antibiotics creates pressure in the environmental. It's called environmental selection pressure. And as I told you before, you may say that, let's go to new antibiotic. But unfortunately, limited treatment options, novel antibiotics like ceftazidime, avibactam, meropenem, veberbactam, they are doing on that. But just look at carefully, there's no new novel antimicrobial class anymore. What we are doing is just playing with the sites of the main molecule and try to cover a little bit more, but you lose that antibiotic very quickly as soon as we started to use it abundantly. And we definitely need some adjunct therapies like the phage therapy. It's progressing quite well, but not ready enough to be used in the clinics. And immunotherapy is progressing, but progressing slowly, not as fast as it has reached success in the cancer treatment. We have lots of antibiotics, but as I told you, none of them are the new class or the modification of the old one, but unfortunately, none of them is good enough to solve our problem. So, definitely, we need to prevent AMR than treating that, as we have discussed that this morning in the vaccine session. Prevention is better than treatment. It's the general rule. So what we got to do for combating AMR in the hospitals particularly, surveillance and monitoring, infection prevention and control, antimicrobial stewardship programs, education and training, and the policy and governance. Surveillance and monitoring is the first thing. I mean, in the hospitals, you must have a program checking the growing the microorganism and be aware of their resistance spectrum. And we have to diagnose them as soon as possible. And this is called the diagnostic stewardship. I'm going to talk about that in a minute. And it's really important, early and accurate detection of the problem. It's called diagnostic stewardship, as I've told you. We have to continuously monitor the infection trends, and we have to work on the real-time outbreak detection using all the possible tools. And until recent years, classically, we have culture. We get blood, we got urine, but whatever is that, and we send the lab, and then grow in 2 days, and then do the antimicrobial susceptibility test another 1 day. This is the classical way, but nowadays we have very advanced new methods, like the microfluids or the proteomics for the resistance detection, or biosensors. I don't have time to go into the detail of that, but in only 1 or 2 hours, you may get the result from laboratory saying that this material contains Staphylococcus aureus and it's methicillin resistant. If you are interested in that and a further reading, I would like to mention about this review, Diagnostic Stewardship in Infectious Diseases. We have published that through the International Society of Antimicrobial Chemotherapy. It gives all the details. And the other thing, so that we will make surveillance and detect all the problems, particularly resistance, as early as possible. And then we have to do infection control, hand hygiene compliance, isolation protocols, and environmental cleaning, preventing device-related infections, multidisciplinary infection control teams. Those are the pillars, but it's not as simple as that. If we make a circle like that, there are lots of special things about the infection control, and it's the activity of the ID doctors. And in each hospital, I'm sure you have that here in Pakistan in the big hospitals, each hospital must have an infection control committee, and they must do surveillance, and they take all the necessary steps, as you see over here, to prevent the infection. Of course, the most important one is hand hygiene. And unfortunately, this is the hardest way. I mean, we do training programs for our nurses and doctors every 2 or 3 months. And we are a big teaching hospital because the interns are changing or nurses are changing. I don't know the reason, but the next training, they forget everything. They still do nothing. I mean, you got to do continuous monitoring for hand hygiene and the continuous training programs. It is very important. There are 10 important reasons for hospital infections. Here they are. If you don't control them, you can control nothing. And thank you. And the new concept, antimicrobial stewardship programs. I mean, for the last 40 years, we are dealing with the infection control, appropriate use of antibiotics, but they all became a big program. It's called antimicrobial stewardship, coordinated intervention to optimize antimicrobial use. I'll be finishing in 2 minutes, and without compromising from the good outcome. Core elements are leadership, accountability, audits, and education. And the important the interventions, pre-prescription authorization to high-risk antibiotics, de-escalation adjustment based on culture results, and regular antibiotic timeouts and prescribed feedbacks. And it needs a multidisciplinary collaboration. In my hospital, ID people, the internists and the surgeons, we all are working together. Please don't feel yourself out of infection control. Without internal medicine in hospitals, we cannot make infection control, just to be sure of that. The antimicrobial stewardship is new. There are some success stories in Europe, and recently in my hospital, we have been certified in the second level, level 2, for the antimicrobial stewardship program. We definitely pay more attention One Health approach, because even if you do your best in the hospital, the pressure is coming from environment, pressure is coming from veterinary medicine. We have to be careful about that. Vaccination is always everywhere. We definitely need good vaccination programs. If you do good vaccination for pneumococcal infection, you will prevent the resistant pneumococcal infection, pneumococcal pneumonia infection, and the vaccination is the only intervention that is proven to reduce the antimicrobial resistance. And for that, all the world is dealing with that. There are lots of global and national AMR initiatives. I'm sure in Pakistan there are initiatives like that. I couldn't dig that out, but we have to be proactive and work on that. And we have some support, technological advancements from AMR management. The new tools like Malditov. You send the bacteria, it identifies in 1 hour saying what kind of bacteria is that. And the AI and the data-driven ASP interventions, electronic health records, will help us in the future very, very well. My dear colleagues, in conclusion, AMR is a complex and urgent global health issue. Effective strategies, including prevention, stewardship, diagnostic, and research, and collaboration is essential to combat the threat. There are some further readings if you are interested, and thank you very much for your attention.
Thank you, Professor Unal, for highlighting an issue that is both urgent and unavoidable.